The goal of this presentation is to show you some clinical examples of several pathologies of the patellar ligament and the trochlea in musculoskeletal ultrasound. All pathologies presented are exemplary and serve as practice for the pathology checklist. The left image shows a longitudinal scan of the infrapatellar region. The right image, a transverse scan of the patellar tendon at the site of the weakest spot. The deep infrapatellar bursa has increased in thickness and cross-sectional area. A small, deep infrapatellar bursa can be observed in many cases, but the size of this bursa is much too big. The bursa has a typical triangular shape on longitudinal scans when distended by small effusions. It assumes an oval convex profile in large effusions, as also shown in the left image. The distal portion of the patellar tendon has changed in shape due to an increase in thickness at the level of the tibial tuberosity. The cross-section of the tendon has also increased. Note that the left part of the tendon shows a different thickness to the right part of the tendon. The volume of the bursa and the cross-section of the tendon seem to correlate. The left side shows a bigger bursa and a thinner bursa. The right side shows the opposite. Some fibres of the patellar ligament have changed into hypoechogenicity. The echogenicity of the deep infrapatellar bursa is mostly anechoic. But hyperechoic parts within the bursa do exist. There seems to be no change in fibre continuity. Based on this static image, it cannot be confirmed whether there is a functional problem. We can assume, based on previous findings, that this patient shows a distal patellar grade 3 or tendon in disrepair tendinopathy and an infrapatellar bursitis, which also contains debris. This conclusion should be confirmed by making a left-right comparison. Measurements of the tendon thickness, tendon cross-sectional area, and bursitis size and volume have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. This is a longitudinal scan of the infrapatellar region. The patellar tendon looks good. This is not the problem. The problem appears to be this superficial infrapatellar bursitis. The healthy deep infrapatellar bursa can be seen in most people. The superficial bursa can only be seen in people who show signs or symptoms. This bursa contains an anechoic substance. Slightly more to distal, we can see a hyperechoic mass overlying the tibial tuberosity. This mass produces an acoustic shadow underneath. We can assume, based on previous findings, that this patient shows a superficial infrapatellar bursitis and a calcification superficial to the tibial tuberosity. Measurements of the bursitis size and volume and calcification have to be made to accurately document the pathology for diagnostic and/or evaluative purposes. The bursitis and calcification should also be scanned in the other plane. This slide shows a spectrum of patellar tendinopathies of two different patients. The upper image shows a diffusely thickened and heterogeneous hypoechoic patellar tendon, reflecting diffuse tendinopathy in the whole tendon. The lower image shows selective thickening of the distal third of the patellar tendon as an expression of distal tendinopathy. The proximal portion of the tendon retains a normal appearance. Never forget to make your measurement wherever possible, and please try to standardise them to obtain reliable and reproducible data, which can actually be used in diagnosis or evaluation. The left image shows a healthy insertion of the patellar ligament to a healthy tibial tuberosity. The right image shows a case of Osgood-Schlatter disease. Most evident is the clear change of shape of the tibial tuberosity. it has become very irregular, a typical sign for Osgood-Schlatter. The shape of the tendinous insertion to the bone has changed as well, due to an increase of thickness because of intratendinous swelling, a result of tendinopathy, and leading to a change in echogenicity. This is a depiction of the femoral trochlea. The thickness of the hyaline cartilage, indicated by the yellow markings, seems to have decreased compared to the hyaline cartilage indicated by the red markings. The cortex of the bone shows at the left side of the trochlea more irregularly than compared to the right side of the trochlea. Overall, one could say that the anatomy within the yellow box looks more vague, with lesser clear boundaries and lines. We can assume, based on previous findings, that this patient shows an osteoarthritis of the lateral femoral condyle. Measurements of the hyaline cartilage thickness have to be made to accurately document the pathology for diagnostic and/or evaluative purposes.